this is not, yes, this is tandem. Okay. So tandem occlusions are very common. Somewhere between 1/5 to 1/4 of all large vessel occlusions are tandem. And they have the worst outcomes in terms of thrombectomy. So every single randomized trial that has included these patients has shown the biggest benefit is derived by patients who have tandem occlusions. So the question is how to treat it. The issue is there's a time constraint. We already just covered that there's a 90% good outcome in 2 hours and it's only 30% at 6 hours. And brain is critically time dependent. So when you consider all of these factors, it becomes, endarterectomy becomes a very poor choice in the setting of a tandem occlusion. You need to mobilize 2 sets of teams. The surgical team needs to come in, and there's the issue of increasing populations who have acutely received thrombolytic therapy, not 6 days ago, but maybe 60 minutes ago or less if you are really fast. And second, and our intracranial lesion is harder to assess with the CEA and TCAR option. It's not optimized for those, although as we just saw, direct carotid stick is sometimes an option. And the same applies to TCAR. So really stenting becomes the primary issue, and then the question becomes, okay, do you stent first or do you stent on the way out? And the way I think about it, it's very simple. Tandem occlusion is the worst case of symptomatic carotid. Why would you not protect the carotid lesion prior to addressing the intracranial circulation? That's my personal philosophy. The data seems to suggest that I might be right, with multiple meta-analyses, no randomized trials suggesting this is 1,000 patients that were treated with tandem occlusions, that when you looked at the results of treating patients with tandem occlusions, these tend to uniformly match the previous randomized trials with almost 50% independence rate, and the complication rates are low and technical success rate is very high. This has been done by other entities as well, with major trials suggesting clear and significant benefit for stenting first rather than not stenting. So it really has become now dogmatic that we do stent these patients, because not stenting ends up resulting in much worse outcomes, higher mortality. And so which stent should we use? Well, or how do we do it? I think assessing the primary causative lesion first prevents distal embolization and improves collaterals up front while you're then going to go intracranial. Others might say, open the intracranial first, let the circle of Willis take care of things. My issue with that is that the guide will continue to interact with an unprotected lesion. So I think that's an issue. So we have looked at it ourselves, and honestly, in our practice, we have not really seen any significant difference of stenting first or second. Others, though, seem to suggest that there is a slight benefit in better safety and better efficacy in patients who were stented first rather than stented second. And I think this is becoming more and more and more dogmatic, and there you can see it's an odds ratio just shy of 2 in favor of stenting. And again, this is additional meta-analyses all suggesting overall slight benefit here in odds ratio of 1.25 in favor of stenting up front. What stent? This a lot of work has been done by our European colleagues. Piotr Muselik and others have published extensively on these next generation mesh-covered stents or much higher porosity stents. I think balloon guides are absolutely critical when you're doing tandem strokes. That is the protection that you use. You have no ability to use filters because you can't see where you're going. And so all you have is your proximal balloon guide. So we universally use balloon guides for these, and that makes a massive impact in terms of good outcomes. And really, when you look at the propensity score matched balloon guide versus conventional guide, massive difference in good quality outcomes with balloon guides compared to conventional guides. And this is not surprising to those of us who treat carotids. You're going to have continued embolization distally unless you stop flow and address proximally. So how do I approach it? In the waning minutes, we'll sort of show you this lesion of a left ICA that comes in, and we use a balloon guide. We cross the lesion with a wire and a balloon. And the balloon actually shows you where the lesion is. So you have to plasty once or twice. Once you know that, under flow arrest, then you can place a stent, and then you just go intracranially. This is an aspiration catheter being snaked, no wire, no catheter, just the catheter itself, and that results in recanalization. Thank you very much.